from Dr. Manfrini from the Folly Institute. The reason why it is so nice for me to introduce him is because we were working together for many, many years, starting when we were very young with Professor Campanacci. And Dr. Manfrini is always focused his attention both scientifically and clinically, besides doing many other things, of course, on pediatric bone tumors and soft tissue tumors and pediatric reconstruction. So the lecture today will focus on his huge experience, 40 years experience of reconstructions in bone in children. Please, Mark.
Thank you, Piero. Thank you so much. Thank you to Thomas Schubert and to all the organizing committee to have invited me. That is really a privilege and an honor to be here in this society that I followed since close to the beginning. My first meeting was in 1989 when there was the joint EMSOS and STS meeting in Bologna. Okay, now I have just to show this. I want to start from the end. Usually we put this type of slides at the end. I would like to start at the beginning because I had the privilege, like many of you, to walk in a very unexplored field. And so I had to do something new. I was forced to do something new. And then I did mistakes. And I think that mistakes were tough sometimes, very tough, but useful. And everything starts from here. This is my thesis in my residency program, and Campanacci accepted the issue because in my residency program I worked a lot in the lab, in pathological lab of Campanacci, and I had to retrieve the specimens that were a lot of amputation. And I had the opportunity to train myself in dissecting leg and dissecting, preparing, harvesting fibula on a cadaveric leg. And so it was 1984, so close to 40 years ago. And this was the title, okay? In an idea at that time. And then in the same residency program, one day I received this specimen. What was my duty to do? I had to cut this specimen, and I cut this specimen. Okay, this was an 11-year-old. He had a resection and such a type of prosthetic reconstruction. For 10 years, this was the younger patient that had a modular megaprosthesis in distal femur. Few years later, the stem broke and bone stock was lost and the prosthesis became longer. And I went back on my mind on this that was a Polaroid, because it was a Polaroid picture, because every time we did the cut, I did a Polaroid, I filled a form with all the information, the measure, and I was thinking, looking this case, could we do something different? Could we do some cut there, or even here? I don't know. And I started to think about that. And then, after my residency, I moved to Florida, where I met these two guys, and the huge collection that Henneking had of macrosection, histological macrosection. And I reviewed all the macrosection of the distal femur osteogenic sarcoma in young patients that were pieces collected without any pre-op chemotherapy. At the time in the US, there was just post-operative chemotherapy. And Henneking had described in this paper the vascular channel in the growth plate, and he concluded that the growth plate was not a real barrier, and so he suggested to do intra-articular resection of distal femur or even amputation at the time. I reviewed all their cases, and together also with the president, we published this paper in Florida that was one of the first papers correlating MRI and growth plate in young osteogenic sarcoma patient around the knee. Then in the same year I spent there, I had in my mind still my thesis about vascularized fibula in hypothesis at that time, and I did some training in microsurgery, and I published this paper in Johns Hopkins University. Then I came back to Bologna, and in Bologna, my mentor, Mario Campanacci, a very curious, lightened guy, completely unusual compared to any other teacher I have ever seen in that time in Italy, he asked me to follow the patient that he sent to Florence because of the microsurgeon unit there, because he liked to do plastic surgery or bone reconstruction using even vascularized fibula that was not well described in the mid-80s. I did. I was very young. I was a fellow. And I needed some help. Who gave me this help? He. Do you know him? Rodolfo Capanna. And this case that we did, I helped him participated to this surgery, was the first intraepiphyseal osteotomy in a proximal tibia. And this patient was brought to Bologna, and I cut to get this histological confirmation. And then this patient also was the first case of the so-called Capanna technique. The first case where we used the compound reconstruction using the fibula inside an allograft that, as you see, was cut with this original design. But then this patient, I followed this patient, and I followed with the idea to look inside and to get at each ear a CT scan, so serial CT scan, that made me understand something new, something never seen before. What was this bone growing in the inner part of the alveoli. This is the first proof that the fibula could work from inside an allograft. And then I continued in Italy to look at the growth plate in osteogenic sarcoma, and I had the help of Franco Bertoni that started in Bologna to prepare macro section. And these are all macro section done in osteogenic sarcoma after here pre-op chemotherapy, not before. And I looked at all these macro sections, and I found the same vascular channel anything I described, but stopped by the chemotherapy. So there was no tumor in the epiphysis, even if the tumor had been so close before. But we had now the figure after chemotherapy. And in this group of patients, the first group of patients we analyzed, there were 4 intraepiphyseal resections and no local recurrence. We are talking about osteogenic sarcoma. In the meantime, I continued to do in Bologna, when Capanna had left, the so-called Capanna technique with an evolution that brought to this case in the femur. That is the first case I did in April 1996, where I put the fibula completely inside a massive allograft in the distal femur. And then I continued to do serial CT in all these patients. And all these patients allowed to me to confirm the osteogenic formation of the bone formation from inside. So the dream come true. We made completely revascularized an allograft. Yeah, probably that seems to be a good way. And we published this evolution in American Journal of Rentgenology that remain the base of analyzing this type of compound construction. At the end of my career, I have in my database this bunch of vascularized fibula used in bone tumors inside Rizzoli after Capanna left to Florence. So this is the Bologna series without the first 77 cases we did together. And mainly femur, tibia, and upper limb, only in long bone. I have in my database 28 free vascularized fibula in long bone, mainly in the upper limb, and I have 43 vascularized fibula together with allograft in the femur, and there were 20 in a parallel construction and 23 in a concentric construction. And then I have also 30 vascularized fibula used to save previously failed allograft. And then I have in the tibia, as we talk right now, 25 free vascularized fibula inside the allograft, and 39 pedicle fibula that I did without microsurgery, because I was able to operate the fibula. It's not so difficult. Of course, we need usually dual incision, one on the fibula and one on the tibia, but it's much easier to do dual incision, and it's a much shorter surgery compared to free vascularized fibula. And I published the comparison more recently. But all success, okay, some problem in the femur. In the femur, the concentric construction, because of the bone, because of the rimming of the allograft to fit the fibula inside, and the plate that sometimes failed, even when the case was alive, clearly alive, because of the CT scan study, they broke. So my personal advice, unless you have a very particular periarticular intercalary resection, is to do parallel fibula with the massive allograft that remain strong. This is up to now my first choice. So, when we talk about failure, because nobody is just light, there is some dark in our job. What is the dark? The dark are for sure the mechanical failure and the septic failure, but really in this series they are not so much. Vascularized fibula is a good help to avoid infection, and the construct, if you do it right, synthesis can be strong. So, which is the worst? In our job, the worst is the local relapse. So the problem is correlated with the indication to find out what was wrong. And it was the worst. The worst, I had 7% of local recurrence, just looking the high-grade sarcoma in this group, so only 136. Osteogenic sarcoma in Ewing, one angiosarcoma, no other diagnosis, never done in a chondrosarcoma of the femur, but could be done for sure. What is the real worst? We deal with people, with humans, and this was a very nice boy, 4-year-old, that presented with the Ewing sarcoma in February 2010. This was the pre-chemo study, and at that time we started to think to what? To rotation blast. 4-year-old, this distal femur. If I have to remove the distal femur, that would be a good solution. Okay. He had chemo. And after 4 cycles, this was the staging study. And so let's take a bet. Let's take a bet to see if it's viable. Completely cold. After 2 cycles, please, to the oncologist. 6 cycles of pre-op chemotherapy. And he did. And look here. Look this. Growth plate. Oh, I love growth plates that may grow so much during preoperative chemotherapy in a 4-year-old. It's wonderful. I can stay there. Cold bed. That's the occasion to fly very high. And I did. I tried. And the report, I received this pathological report. Wonderful. 100% of necrosis. The oncologists were happy. Champagne, free margin. Wow! We won! And the boy started a few months later from the surgery to run in the ward during chemotherapy. And the growth plate was growing. And I removed the screw in the epiphysis. Could start again the growth. We won. Still in November we were happy. Still in November we were happy. But we shouldn't be happy. Because look here, something wrong. We realized it a few months later when the patient came back to control. And it was like that. What could I do? I just do an amputation. Okay, we lost. We lost. And follow the patient. And in June 2013, bone metastasis occurred, and this boy passed away, age 7. Today, this boy came from Naples. That means that today he could be there. So, if you want to fly too high, when you fall, it's tough and painful. So, why we didn't push enough for rotation plastic? Why? The ego of the surgeon can be the worst enemy of each of you. Now, let's take a pause. This is a 17-year-old girl dancing. In the same time, in the same time, remember the date. In April, I did the previous surgery in July 2010. In April, I had received such a case, 3-year-old osteogenic sarcoma, huge tumor involving the vessel here. What you think you can do? If you want to cut the femur there, you have the remaining stump just 5 centimeters and you have a 12 centimeter of resection done, do you think any expandable prosthesis can stay there? No. And look at the femoral canal. The femoral canal is 6-7 millimeter. Which kind of stem are you going to put there? So, this girl, who at 3 years old in 2010, and now walk like that, is the girl that was dancing. Okay? That's why I think rotation plastic, it's a mandatory indication in small children. Whenever we have the space to do anything else, and if the femur is long, I said 25 centimeters because there is no space to put anything else. And rotation plastic has a wonderful, even functional and I think also psychological long-term outcome when you do in children. So, but we looked also other ways. One of the best ways we looked was this one, was alloprosthesis composite in children. This was done in the proximal femur in half 96, in the distal femur, as Laura Campanacci showed previously, in December 96, in the proximal humeral I started in January 2003 with the resurfacing cup, and then I did few cases in the distal humerus, and I did few cases in the distal femur. The first was done in Turin in 2007, as someone showed before. The first case was this one, and we started the idea. Campanacci was worried about the fixed head in a native children acetabulum, so we wanted to use a bipolar head, and the only available at the moment was a 36 millimeter size, and that's it. So before that, in younger patient, I tried again something original. It was this one, to put the vascularized fibula inside an acetabulum, and I did in a 4-year-old girl in 1997, and this worked so nicely in the first few years that the fibula adapted to the native acetabulum, then had also a fibular femoral epiphysiolysis, but I was able to fix with minimal surgery, and the patient at the end came to walk again, but 4 years after surgery, 4 years of protected weight bearing in such an age group. And I became a little famous for that, okay? I was happy, a lot of interview, newspaper, something. And that graft is still there, 26 years after surgery, so it's possible. Is something possible? But I did other 4 times, all failed. All needed a revision with a bipolar cup. I was able to preserve the allograft when they were children, and then 3 of them were revised in total hip replacement, and those 3 at the end needed also a proximal femur implant. But I was happy that I was able to preserve the limb, the knee, and also the leg discrepancy. So in 2006 I said, why go in this way? Let's try the fixed head. Why don't use the fixed head? No report before that there. This was a 4-year-old. I found a very small allograft. I put a fixed ceramic head. I studied. The acetabulum grow only if there is a growing head inside. And now it's still there. No revision. No revision. She started to walk after 3 months when she was 4. So this is the way. Not that one was a mistake, was an hallucination. Okay? Like Now we have changed GPT hallucination. We have surgical hallucination. And so when I received the youngest Ewing I have ever seen in my life, came to me that she was 15 months, and I did surgery when he was 17 months. She had broken while in the first attempt to walk. And in the first, I studied. I did what I could do in 2013, a 3D modeling. I found an allograft. I found a humeral contralateral side allograft that fits much better in the right femur. And then I put inside the smallest available stem in the market, a completely polished Exeter type prosthesis for this plastic hip, but was too long, and so I had to cut. Completely, my career has been completely out of the box, off label, completely out of the box, because while the patient was still under anesthesia, I prepared the allograft, I cut the stem, I cemented the stem inside the small allograft, and when the patient entered in the room, we had already, like that, with such a graft. And what happened? Another miracle of biology. It's just biology. We had just to follow biology. Look what happened in the following 2 years. Look the distal femur. The distal femur grew. The bone stock doubled. And this is, in my knowledge, the first human being that started to walk on a hip prosthesis. Okay? So, nice. Now, of course, the patient grows, the implant breaks, and I redid, this time without cutting the stem, and then grew, and then grew, and then grew. There was some deviation. I put a staple, and then the staple worked, and they are coming close. The deviation was corrected. Of course, there is a shortening. And recently, in the last 6 months, we did 3 times surgery on this patient because we put a cap, maintaining the previous one. Then there was a dislocation because it was not, the office set was not anymore enough, and I changed it again, broke, and we changed it again. So, I love children, and in this age group, the erythrolysis involved 257 patients in the last 30 years, and 200 are in the long bones. If we look long bones, with this, the range of our indication in the femur, tibia, and humerus. Take a look that in the tibia, we never did in this age group a prosthesis in the tibia. Never, until I am alive. In the humerus, we did a lot of graft, vascularized fibula, just a few prostheses, but look at the range of graft. We need a bone bank. We need massive allograft for children. We need, it's something that the scientific society has to defend this type of opportunity. We need bone banks for children. But we did also megaprosthesis. If you want to know something about my feeling about the megaprosthesis, of course we did. We did expandable. And we did the first type that was a junk that completely, in a few years, and we contributed to bring this type of prosthesis completely out of the market. It was a very fake type, another hallucination of the technology this time. And which is the ideal type of prosthesis for a child in distal femur? Is something that we have to answer to this question. The femur has to be cemented or uncemented. The body has to be magnetic or mechanical, and the tibial component has to be hinged or rotating. Okay, the stem. My personal idea of stem is something that we tried with Stanmore. This is a completely polished stem, and this is the result 7 years after. Do you see any stress shielding phenomenon? And do you think it will be difficult when this stem could be revised in the future? It's completely polished. The anchorage is just here with hydroxyapatite coating for 15 millimeters. The function is wonderful. I don't show the movie, believe me. The expandable body. Okay, we use two types, mechanical and magnetic, that are now out of the market. That's another awful hallucination of the market technology. There are particular problems to take in account. This is the youngest patient we put a mechanical striker, and this youngest patient we were able to bring at the end of his growth with several surgery. Several elongation surgery, minimal, and 4 major surgery, because after the elongation we went back and put spacer, because there is a modular system. It's fine to have a modular system in this type of reconstruction, because you can add pieces a long time. But of course it was much better the magnetic from the expansion. The magnetic is minimally invasive. This girl worked nicely and is still there with the expansion completed and works very well, very well. But not always. And here we realized something that we didn't know, because this was the only available joint that the company gave to us. Awful to understand that 50% in our series, but I have seen other series too, so we had to revise with another expandable prosthesis. Of course, we were able to reach a good result at the end, but never use a rotating hinge, please, never, because in children overall, I say, never. We need an hinged knee. Okay? Okay, I skip these 3 because they say something that is not really important. I go to the answers. Cemented or uncemented? I prefer uncemented. Mechanical or magnetic? Doesn't matter. Depends something that has to be what? The femur stem has to be customized, so we can do how we want. With the preoperative study, we need a procurvated stem, we need a collar, can be hydroxyapatite or some other material, we need to have an anchorage just at the close to collar, just close to collar. The expandable body has to be reliable. If I do, has to work, strong and durable, because it can be expanded for years. And the joint tibial component has to be hinged with a minimally invasive tibia to allow the growth of the tibia. And so, do we have something on the market? We have to look for. I don't want to push anybody. Here, the company is not present. In Italy, we are trying to use this system, because this system, this is a case done by a colleague, anyway, allowed to do a completely customized stem with the same parameter I was telling. And the hinged knee, it works, seems to work. Okay? You have to think about that. Alternatives, okay, you saw something. The alternative is this one, if you want, and this boy, done in 2017, is going to be elongated with an intramedullary nail in the next few years. So, that's the last one. I have to thank all my colleagues. even the younger that are not here, because Campanacci was a wonderful person that was able to listen also the younger resident. I was the younger resident for a while, and he was able to listen and to think about. Continue on this way. Please, my friend. And that's it.